Welcome to the GlycanTrigger podcast series. Over the course of 12 episodes, we will engage with experts in inflammatory bowel disease, patients, and other relevant specialists, delving into their work and exploring the challenges within the GlycanTrigger project.
Hello to all and welcome. Today we have our second episode of GlycanTrigger Project podcast series. I'm Leticia Gomes, a postdoctoral researcher at I3S working in behalf of the GlycanTrigger Project. GlycanTrigger is a project funded by the European Union through the Horizon Europe Research and Innovation Actions, which started in January 2023. This project aims to understand the intricate interplay of factors that contribute to the transition from healthy state to a chronic inflammation in the gut. Specifically, it explores the changes in gut glycome through this podcast series as well. We'll then engage in biannual discussions with experts in inflammatory bowel disease, patients, and other key stakeholders connected to the GlycanTrigger project. Today's discussion is focused on the bridge among the gut permeability, intestinal barrier, and inflammatory and autoimmune diseases, where we will have the insights from ENDOTARGET, one of our sister projects. ENDOTARGET, which also started in January 2023 and is led by Helsinki University Hospital, aims to explore the relationship between gut microbiota, intestinal permeability, and systemic endotoxemia. It aims to understand their role as drivers of disease onset and disease activity, as well as targets of preventive and therapeutic approaches. Their research is focused in three main rheumatic diseases, namely osteoarthritis, rheumatoid arthritis, and spondyloarthritis. So to join us today for this discussion, we have invited Dr. Patrícia Costa Reis, a specialist in autoimmune diseases and a pediatrician at the pediatric nephrology and kidney transplantation unit in Hospital Santa Maria in Lisbon. Dr. Gonçalo Barreto is an associate professor and principal investigator at the University of Helsinki, whose research focuses on understanding innate immunity signaling and novel regulators in osteoarthritis. Dr. Gonçalo is currently Deputy Coordinator of ENDOTARGET project. And Dr. Salomé Pinho, the Project Coordinator of GlycanTrigger and Group Leader of the Immunology, Cancer and Glycomedicine groups of I3S, already known from this podcast series as well. Welcome to all of you. So I think I'll start by asking Patrícia to introduce us gut permeability and tell us what are the primary mechanisms by which the intestinal barrier dysfunction contributes to the pathogenesis of inflammatory and autoimmune diseases.
So hi, everyone. It's a pleasure to be here. It's a pleasure to collaborate with GlycanTrigger, and it's a pleasure to discuss this very interesting and hot topic issue. So there are lots of unknowns, but there are also things that we do know. And we know that we have in our gastrointestinal tract a very diverse and large community of microorganisms and believe in symbiosis with these microorganisms. And they are going to modulate our immune system. They are going to really modulate the gut-associated lymphoid tissue, but not only locally, but also in a more broad way. But what we know is that when we have dysbiosis, when we have a higher gut permeability, there are components of the bacteria and metabolites of the bacteria. For instance, LPS, the component of the part of the membrane of gram-negative bacteria that are going to cross the barrier. So if you have a dysfunctional gut barrier, if you have a leaky gut, you are going to have more LPS going into the bloodstream. So we call it endotoxemia. Endotoxin is another name for LPS, and you are going to have more LPS in the bloodstream. So what we do, there are different forms of LPS, but in a very simplistic way, if you have a higher gut permeability and if you have more of this substance, more of LPS in the blood, you are going to have a chronic activation of the immune system. So if you are already genetically predisposed to have an immune-mediated disease, this will be another form of having a chronic activation of the immune system, and you'll have a higher risk of developing of one of these diseases. This is so important that in mouse models, for instance, in a lupus mouse model, if you have these mice, and if you use certain vaccines against certain microorganisms or certain antibiotics, these mice that usually develop a very severe disease, they don't do it anymore. So if you modulate the microorganism that you have in your gut in a mouse model of an immune-mediated disease, you can have different types of severity of the immune-mediated disease. So this really shows how there is a direct effect of the gut and of the microorganism that you have in the gut in these immune-mediated diseases. That's why this is so interesting to study. So there are many, many factors that can correlate and that are associated between our gut, the microorganism that we have in our gut permeability, and the state of inflammation and the risk of developing immune-mediated diseases. And it's not only the arthritis-related immune-mediated disease. If you think about other diseases, neurological diseases, they are also associated with. So this is a very broad mechanism that is associated between the gut and the inflammation that we have in our body.
Okay, and do you think that, or is it known what are the most significant changes in the gut microbiome that are observed in this inflammatory or autoimmune diseases, and if these then lead to different kind of LPS, which can be maybe a bit more severe in the sense?
So what is difficult in this field is that different groups have found different organisms that are associated with a certain disease. But then if you try to replicate in different parts of the world, we don't have the same results. So the way that we eat, our diet, and also some genetic issues are different. So the microorganisms are not really the same in different studies. But what we do know is that in a very broad way, in immune-mediated diseases, the greatest risk is if you have a low diversity of your gut microbiota. So the idea is you have to eat well, and you have to have a very diverse community of microorganisms in your gut, and that is your healthy gut. And if you don't have that, and if you have, for instance, if you don't follow a Mediterranean diet, and if you have a low diversity of your gut microorganisms, then this is associated with a higher risk of immune-mediated diseases. So it's not really just one microorganism. For instance, for lupus, there is one that has been described several times, but then you try to replicate and you don't find it anymore. So some groups showed one, and then they showed that it's associated with lupus nephritis, so the renal involvement in lupus, and with certain levels of autoantibodies that are really important for the pathogenesis of the disease. But then in other groups, you really didn't find that the same level of evidence. So it's a more broad idea. You really have to have diversity. That's the really important thing.
Okay.
Yeah, and if I could just add as well, in terms of the bacteria that have been associated with certain diseases, we know, of course, in terms of LPS, different bacteria produce different LPSs which have a different activation profile in terms of creating either a tolerance or an inflammatory response. So, but it really still depends, what are the commonalities between certain diseases, and can we replicate, bacteria that are associated with a certain disease in Finland and reproduce it, and is this observed as well, for example, in Lisbon? So this is the main challenge now in the field.
So maybe I can add something here, maybe to Patrícia. So Patrícia, as a pediatrician, it is actually quite known that in a subclinical phase of rheumatoid arthritis or other immune-mediated diseases, there are evidences pointing towards the fact that alterations in the microbial community already exist, right? And these could actually foster towards this notion of this connection between the gut and the joint. So is that something that you deal in your clinical practice with these microbiome alterations in a subclinical phase, take in consideration that you are dealing with the juvenile context of the disease? This is something that is I believe that it's not common still in the clinical practice, but there are evidences, right, that points towards a microbiome alteration, that dysbiosis is still in a subclinical phase of the disease.
Sure, and that's really interesting, and that's exactly what we want to know. If we are talking all about studying from healthy states to disease, and if you can abrupt that, if you can interrupt this cycle, and if you can stop the arthritis, I wouldn't say, I don't think that this is cause consequence, and I don't think that if you don't have a genetically predisposed individual, this is not going to make the same difference. But what we do know is that if you already have a predisposition and then you have a diet that is not the right one, then you have a higher risk. So if you can interrupt that in a pre-arthritis state, and if you can improve, I have lots of patients that ask, and families and parents that are worried, and they ask about diet, and they want to take certain foods of the diet of the child. And the child and the teenager, they have to grow up, and they have to have a very well thought diet, and we cannot interfere with growth. That's really important, and with health and global health. So some families are worried, and they want to do a very certain diet that doesn't have certain elements, and they want to take, for instance, milk, and they want to take gluten and other things like that, and you don't have evidence for that. So what we do have evidence is that if you follow, for instance, a Mediterranean diet, which is really difficult to follow because the number of fruits, the number of vegetables, the level of meat that you have to eat is lower than what we usually eat in our Western diet. If you do follow that diet, then you are going to have a more diverse microbiota, and probably this might help with the progression of disease. But some families are worried about a certain food, and for that you don't have evidence. So it's more a global advice that you are having arthralgias, you might not have arthritis, but you have just pain in your joints, and you have, for instance, family members that have spondyloarthritis, or they have RA also. So you are a high risk child to develop juvenile idiopathic arthritis. What you can recommend is, of course, a Mediterranean diet, which is a good advice for everything. So it's never a bad advice to recommend a Mediterranean diet. That is what I would say.
And if I may add, we also have the counter evidence, at least in the preclinical models, for example, of osteoarthritis, that if you feed mice a high-fat diet, that is clearly associated with increased severity of the disease. But however, we still cannot pinpoint exactly these through gut-mediated mechanisms, but other like weight bearing and other associated factors. So the causation is still unknown exactly what are the main roots of how the diet interferes with the disease.
Mm-hmm. And now maybe a question, firstly, at least directed to Gonçalo. How significant is the understanding of the mechanisms behind gut permeability in the context of then developing new treatments from inflammatory and autoimmune disease?
Well, we know that there are main mechanisms that are associated with the disturbance of the gut barrier. So we know that mechanisms such as increased mucus production and secretion can impair the gut permeability. We also, of course, know that the altered expression and distribution of the epithelial junction complex are known to interfere with that. And of course, when you have disruption of the barrier, you have potentially, of course, translocation of bacterial translocation, but also translocation of certain metabolites. And of course, we also know that certain cytokines which lead to intestinal inflammation can impact and modulate the intestinal permeability. And this, in terms of as a therapy to modulate the intestinal permeability, this is something we are actively seeking to research at ENDOTARGET. And in fact, we have a clinical trial planned where we are using a peptide called larazotide, which is a zonulin antagonist, which is one of the main mediators of the epithelial tight junctions on the gut, where we in fact want to try to see, by modulating the gut permeability, can we impact the efficacy on rheumatoid arthritis in untreated or to moderate severe patients. So this is something we are exploring.
Maybe as a follow-up question, Gonçalo, but do you think that would be better to inhibit this leaky gut through inhibition, for example, of zonulin, which could be one of the targets? But what about preventing the gut permeability alterations before?
So, yeah,
right?
okay,
So,
yeah. So we also have those studies, and actually, the Lisbon colleague is, of course, the best to explain, where we have actually clinical trials with a diet intervention, where we are trying to see if these certain diet interventions, such as the Mediterranean diet, can lead to a better outcome of the disease, and what happens, in fact, on terms of gut permeability. Where we are measuring direct biomarkers of gut permeability, but also looking some of the potential causative agents of the disease, such as LPS, which was named before.
So I
So
can add a
yes.
little bit, on that. So we are trying in two different ways. One is the tasty study, and the idea is exactly that, is to understand if we change the diet of a patient with rheumatoid arthritis, and if they follow the Mediterranean diet, we are going to see a difference in disease activity or not. So for a couple of weeks, and we are doing this with the help of the nutrition team from Faculdade de Medicina de Lisboa. So it's Lisbon University nutrition team, and what we are doing is that for a few weeks, the patients have nutritionist support every week, and they have food that is delivered to their homes, and so to help to follow the diet correctly. And they also have workshops, culinary workshops, that they learn how to cook, and they have a very tailored nutritional plan that is adjusted to their needs and what they like, so that they can follow a Mediterranean diet. And we study the permeability, the gut permeability, by the lactulose mannitol test at the beginning and at the end of the trial. And we study lots of markers of gut permeability, of endotoxemia, and also disease activity, using questionnaires, using ultrasound, and using the clinical activity marker that we usually do to understand rheumatoid arthritis activity in the clinical practice. So in this study, what we want to know is that if you really follow a Mediterranean diet, are we going to see a difference in inflammation or not? So that's one part of the studies that we are doing. And the other one...
Sorry, Patricia, to interrupt. The primary outcome would be disease activity.
Yes.
So for how long the intervention, the dietary intervention will...
It's 12 weeks.
Occur?
12 weeks.
Okay.
Yeah.
But what is your opinion about, because this is already established array, right?
Yes.
It's in the beginning, so I believe that there are some eligibility criteria. So it's not a severe disease. I believe that mild disease, because to have some effects in terms of disease activity. And also just to have your opinion on whether do you think that this could be more effective in a subclinical phase as a preventive approach. Just some food for thought.
Salomé, I completely agree that the subclinical phase would be wonderful, but it's very difficult to recruit, very difficult to have the exact measure of how we were going to see the difference. So in terms of, is this important and is this useful clinically? I do think it is, but it's more difficult to put into practice in terms of a study. And the other question, you were telling me how the inclusion and exclusion criteria for this study are difficult, because we want patients that have active disease, but these are patients that cannot have extra medications while they are in the study. So they cannot have a disease status that the clinician that is following this patient wants to increase the immunosuppression. So we are talking about patients that are, for instance, on methotrexate or even on biologics, and the disease is not in remission. There is some activity there, but the activity is not so high that the clinician wants to increase the immunosuppression, or the patient has some contraindications to increase the immunosuppression. So we are going to add this study with the diet to see if we have a difference or not. So it's very difficult to recruit these patients because they have to be active but not too active. It's tricky. It's tricky.
Yeah, I imagine that. And now a bit to change to Salomé and to direct a bit to the gut joint axis, because gut permeability is in the gut and it's known. And here we've been talking about the rheumatoid arthritis, so the different disease, but there's different studies about the access from the gut to different organs actually. And specifically about this gut joint axis, Salomé, what is it known about how gut permeability can influence or drive different inflammatory and autoimmune diseases actually in the same individual?
Mm-hmm. Yes, I think this is pretty much the purpose of this collaboration between GlycanTrigger and ENDOTARGET. So we are pretty much interested in GlycanTrigger in analyzing how the mucosa glycome, which is actually a very important layer at the surface of the gut mucosa, a master interplayer with the microbiome, but also with the immune system. And we are interested in dissecting how this mucosa glycome has a role in health to inflammation transition. For what regards this potential gut joint axis, I think we have many evidences that support this hypothesis, because it's still an hypothesis. We have the commonalities of patients that exhibit more than one autoimmune disease. So IBD, for example, with spondyloarthritis or other types of arthritis, patients with IBD that also exhibit psoriasis. We have also patients with IBD, for example, with hidradenitis suppurativa, which is one of the projects that we are dissecting. So these commonalities and the fact that patients can start with a subclinical gut inflammation associated, for example, with the expression of spondyloarthritis, I think these are evidences that support the fact that there are a kind of a common pathway that eventually link the gut to other target organs, such as joint. I think this makes all of the sense actually in line of what we have been discussing. So alterations in the gut permeability, the so-called leaky gut, will facilitate the entrance of microorganisms, of bacteria, and the secretion of some factors that would activate immune response. And by activating immune response, I'm saying about innate immune response, but also antibodies production. And talking about antibodies production for the sake of inflammatory bowel disease, we have this very important antibody, which is ASCA. So this anti-Saccharomyces cerevisiae antibody, in which we are pretty much interested. But it's also very interesting to know that, for example, HS patients, so with hidradenitis suppurativa, which is another autoimmune disease, interestingly, they also exhibit increased titers of ASCA. So this is actually supports the fact that these alterations at the level of the gut mucosa, through alterations in gut permeability, dysbiosis, subclinical inflammation, would potentiate the production of these autoantibodies that will drive to other target organs, contributing to the extra-intestinal manifestations of the disease. So I think this is pretty much the aim of this collaborative project between GlycanTrigger and ENDOTARGET, and I'm very happy and excited about this.
Yeah, and if I just might add on the gut joint axis, one of the main objectives that we actually have at ENDOTARGET is looking at the specific molecule. So it's a bacterial endotoxin, lipopolysaccharide, where we are trying to see not only its association, because most of the studies so far have looked at associations of gut dysbiosis or gut-derived metabolites, but we are trying to pinpoint and look at really at the causative effects. And we are trying to distinguish in ENDOTARGET specifically for the disease of osteoarthritis with preclinical models, when this bacterial endotoxin LPS leaks through the gut, when the patients have an altered permeability, are its effects mostly systemically or locally directly on the joint. So we have samples collected from patients, both serum samples or synovial fluid, which is the liquid that you have in the synovial joints, to look directly, do we see a correlation between the two? And do we see a correlation with the disease activity? And then we have animal models where we directly inject this LPS either systemically or locally on the joint and try to demonstrate the causation effect that is still lacking currently in the literature.
Yeah. Interesting.
And now maybe Gonçalo, since you can continue a bit talking. We speak a lot about the gut dysbiosis, and that this can also is one of the drivers or can lead to gut permeability as well in different inflammatory diseases and autoimmune diseases. Do you know if there are, or what do you think about the specific patterns or biomarkers that are associated with different conditions? So do you think that it's actually something that might be transversal through the different diseases, or can you pinpoint a pattern in dysbiosis or a biomarker that would then be associated with specific autoimmune conditions or inflammatory conditions?
I think Dr. Patricia has brushed a bit on this subject before, so pinpointing that is actually very hard to identify a specific bacteria or a class of or genus of bacteria. But of course, we have seen from the literature there are some common bacteria such as the Streptococcus genus, which is associated with ankylosing spondylitis and rheumatoid arthritis and Sjögren's syndrome. And we also know, for example, certain class of genus which are depleted, where you have an imbalance of this genus. And of course, a very fast literature search will always come up with Prevotella copri, with one of the main bacteria associated with rheumatoid arthritis. So this is mostly at the bacterial level. But in terms of biomarkers and associated biomarkers, endotoxemia has been one. So looking at purely just at the concentration of LPS on the bloodstream, what we are doing at ENDOTARGET, we are trying to go one step further, not looking just at pure concentration, but rather its biological activity, because as we mentioned before, LPS, the bacterial origin of LPS has a different effect, biological effect in terms of activation, namely of toll-like receptor 4. So we are trying to look more specifically on its bioactivity, and we have evidence from previous works where this bioactivity is associated with rheumatoid arthritis progression. But we're also looking at surrogate markers associated with LPS, namely CD14 and LPS binding protein. In the side of the gut dysbiosis, we are looking at the classical marker of leaky gut, which has been established from other diseases, but now coming also to the arthritic diseases, which is the one called zonulin that we are testing heavily in our patient cohorts, and also looking at markers of intestinal inflammation, namely intestinal fatty acid binding protein.
Okay.
And to one that we are actually not doing, but many people are, is a field that is moving fast, is actually people are looking at the microbial DNA, not on the gut, but actually directly, for example, on the synovial fluid. So there is evidence that DNA can leak and accumulate, for example, on the joints, and try to have an idea what is the microbiome, although I don't like the term to refer it to microbiome because it gives the idea that you have living bacteria in your joint, but this is something that people also are looking at.
It's everything very promising, I'd say. And now to Patricia, and looking a bit at the emerging therapies that are ongoing, like personalized medicine, or for example, one that it's been increasingly studied, the microbiota transplantation. So how do you think that this fits into the treatment landscape for autoimmune diseases?
So with the fecal transplant, we were all very excited with that. But some studies with fecal transplants in other immune-mediated diseases like psoriatic arthritis, they have not been, the results have not been as good as we would like. So we are less excited than we were a few years ago. In ENDOTARGET, we also have a study that is being developed in the University of Helsinki with the fecal transplant, and we are going to have the results of the study next year because the recruitment is already closing. So hopefully in a few months we are going to have the results and we can discuss that. But it's not as promising as before. And what we do think that is happening is that even though you do a fecal transplant afterwards with your diet and with your lifestyle, the microbiota is going to change. So the differences are not sustained, and that is a problem. So that is one thing regarding the fecal transplant. But then Gonçalo already told about other strategies that we can use to decrease the leaky gut. And I also would like to add another thing. We have been discussing if you have a diet that is not correct, you can have different microbiota and you can have a different permeability of your gut, and then you can have a higher risk of inflammation. But it's not only that. If you also have a disease and if you are taking medication for that disease, that is also going to change your gut permeability. For instance, if you have arthritis and if you have pain and if your doctor prescribes you an anti-inflammatory drug, which is very, very common, the anti-inflammatory drugs are, and we know that really well, they are going to change your gut permeability. They are going to increase it. So they are going to increase the possibility of a leaky gut, and this will also contribute to higher endotoxemia, and it will also help to the chronicity of the disease. So it's much more complex than just, okay, we have a different diet, not as good as we would like, and then we have inflammation. It's more than that. The drugs that we use to treat inflammation can also help with this mechanism. So doctors, when we give, for instance, steroids, when we give anti-inflammatory drugs, we usually also give a drug that protects your stomach. We use, for instance, omeprazole to protect the stomach when we give NSAIDs, when you give non-steroid anti-inflammatory drugs. So what it can happen in the future if whenever you are using drugs that interfere with your gut barrier, probably will use an extra drug to stop the higher permeability. So we are talking about different ways to control the inflammation and to control the disease activity. So the first question with the fecal transplant, that's my idea of how we can think about it. Then we have other possibilities to interfere with the gut barrier, and Gonçalo already talked about one. So zonulin is really a protein that has been studied in different diseases, and it has been associated with celiac disease, and it has been associated with dysbiosis. And several groups in our consortium in ENDOTARGET have studied zonulin for a long, long time. And we have shown in different diseases like lupus, like spondyloarthritis, that zonulin is really elevated. And we know that zonulin is going to disassemble the tight junctions between enterocytes. So it's a modulator of gut permeability. So one of the ideas, as Gonçalo already said, is using an antagonist of zonulin. If you do that, probably your gut barrier is going to be better and you are going to have a lower risk of a leaky gut. And this may be helpful. So that was the main hypothesis that we use to design a study to use larazotide in early rheumatoid arthritis. So that would be another option. But there are several. So there are several ways of trying to interfere with the gut barrier, with the gut microbiota, but we are still...
diet. Including diet.
Exactly. So lots of things going on.
So this was already kind of a wrap up and comes in line with the final, I guess, question or comments for all of you to do, which is the therapeutic strategies that this big European project, such as ENDOTARGET and also GlycanTrigger, have to or can develop from the knowledge gained from this research that it's going on. So maybe first the ENDOTARGET partners can speak a bit, since this has already been kind of pinpointed throughout all this discussion, and then also Salomé about the GlycanTrigger.
Well, I would say that, this is just exactly what Patricia has just answered in the previous question. So these are the current therapies that are cutting edge research and that are the most promising currently.
Mm-hmm.
Yes, I think from the GlycanTrigger perspective, we are pretty much interested in intervention through diet. I mean, exploiting the power of glycans as promising intervention strategies to prevent health to inflammation transition. I think if we prevent this impact in the integrity of the gut barrier, I think we'll prevent eventually zonulin dysregulation, or eventually a synergistic approach that would be through the dietary intervention with these inhibitors of the gut permeability through inhibitors of zonulin could also be an approach. But I truly believe that the combination of diet, the exposure to some environmental triggers, and if we can control that through diet or through a healthy lifestyle, I think this is still a way of preventing, and I'm talking about prevention of this health to inflammation transition. Yeah.
Yeah, so thank you very much to all of you. I think we got a pretty good broad view on what has been going on, specifically in these two European projects, ENDOTARGET and GlycanTrigger. And there will be for sure exciting results in the coming next years that will engage in and develop into hopefully new therapeutic therapies that can then improve the lifestyle of patients that are actually suffering with these diseases. So thank you very much to all of you.